Good evening. I'm very pleased to welcome you to our third annual COS Forum, Eyes on Tomorrow. I'm Dr. Mona Dagger, President of the Canadian Ophthalmological Society. Tonight, we focus on the future direction of the COS and ophthalmology in Canada. And we hear from speakers on advocacy, barriers to corneal donation, ergonomics, ethical considerations, and the annual meeting and the update on the AI stream preview. While we are getting ready and everyone is logging on, I will highlight a few COS initiatives that you may not know about. Have you listened to the ICANN podcast? We're now in season 5 of this uniquely Canadian lens on ophthalmology. This season, hosts Dr. Heather O'Donnell and Dr. Hadi Saheb will be speaking with experts and guests on topics surrounding ophthalmology, including and not limited to artificial intelligence up to capital gains. These podcasts are perfect for the commute home or your walk with the dog. So check them out on Apple Podcasts, Spotify, or any other place you get your podcasts. If you haven't checked out the See the Possibilities website lately, it's worth a visit. There's so much new content for the public, including information on common eye conditions, risk factors, and treatment options. There's also Ask the Experts series, where Canadian ophthalmologists discuss common eye health conditions. There's also fun and informative tests and quizzes to tackle common eye health misconceptions. And there's also a breakdown on who's who on the eye care team to help people make most of their eye health journey. So it's a great resource for anyone, including patients, looking to learn more about eye health. Speaking of lots of great information, this is for you, the ophthalmologist. Have you browsed through the Practice Resource Center? This online portal is a great resource of information, clinical tools, position statements, and CPD offerings. You can search those opportunities by subspecialty, by type of learning, such as Section 1, 2, or 3 credits, or even through the easy-to-use calendar. Whether you're searching for one particular item or browsing the deep well of information, the PRC is your one-stop shop. The Sally Lesson is a 2.5-day program in Ottawa that provides an in-depth look at specific topics in ophthalmology. This year, the focus will be on uveitis, with experts speaking and sharing on key developments and practical insights on this important topic in ophthalmology. Stay tuned for more detail as we approach the event. So if you're just logging on, you are in the right place for the COS Forum. We will be starting shortly. Good evening, everyone. I'm very pleased to welcome you to our third annual COS Forum, Eyes on Tomorrow. I'm Dr. Mona Dagger, President of the Canadian Ophthalmological Society. And tonight we will focus on the future direction of COS and ophthalmology in Canada. We'll hear from speakers on advocacy, barriers to corneal donation, ergonomics, ethical considerations, and the annual meeting update, including the AI stream. I have no conflicts of interest to disclose. This webinar is an accredited group learning activity as defined by the Maintenance of Certification Program for the Royal College and Physicians and Surgeons of Canada and approved by the COS. That means you can get Section 1 credits for 1.25 hours that you spend with us in the mock program. The COS will be sending all participants an email shortly after the webinar with an evaluation link. Once you have completed the evaluation, you will be able to download your certificate of attendance. The learning objectives of tonight are to understand how COS is advocating for policy changes at the government level to improve eye care accessibility and quality, to be more aware of the latest information on ergonomics and injury prevention and how the profession is affected by injury. It's also to know more about the status of the COS Annual Meeting in 2025 and provide information on our new stream on artificial intelligence. We'll also understand the importance of ethics in our profession and learn about the virtues exemplified by the ethical physician. Before we get started, Just a few housekeeping notes tonight. You'll hear from 5 speakers. After each presentation, there will be a Q&A session. As you listen, feel free to post your questions in the Q&A tab at the bottom of your Zoom screen. I'll do my best to share as much as possible with our speakers, and they'll answer. At the end of the evening, we're hoping to have a few extra minutes to circle back to any remaining or follow-up questions. So tonight, we're looking forward to your engagement through polls that will pop up during the presentation, like this one, to get you more comfortable with the feature, especially if you haven't used it before. Here's a quick practice poll to try out. The first question is, what's your favorite way to spend the day off? A, exploring the outdoors. B, binge watching a series. C, cooking or baking something delicious. D, diving into a good book. Or E, catching up on much needed sleep. So we'll give you time to answer. And as we tally the results, I'll give you a few moments. There we go. All right, so it's pretty diverse, and I like that. Perfect. They're all great answers. The goal tonight is really to give you the opportunity to reflect on the role and impact of the COS, helping you put its contributions and future direction into perspective. The COS is really the national authority for eye and vision care in Canada, bringing together over 800 ophthalmologists and 200 residents and fellows. We are committed to assuring the provision of optimal medical and surgical eye care for all Canadians by promoting excellence in ophthalmology and by providing services to support our members in practice. Through collaboration with government, national and international specialty societies, and healthcare professionals, we advocate for eye and vision health policies, including the recent passage of Bill C-284. We have developed a close working relationships with Health Canada to alleviate ophthalmic drug shortages, and we continue to inform the profession of current or pending shortages. COS is also proud to be an accredited provider of CPD, so continuing professional development, ensuring our members stay at the forefront of our field. And finally, we're all very excited to bring together ophthalmologists from across Canada at our 2025 annual meeting and exhibition happening in Vancouver from June 19th to 22nd. This meeting showcases an outstanding international and Canadian faculty presenting the latest in ophthalmic research and practice. You'll be hearing more about it later too. As a reminder, as you listen to the presenters this evening, you can post your questions in the Q&A, and we'll do our best to get as many as we can. So without further ado, I'd like to kick off the evening by welcoming our first speaker, Dr. Nina Ahuja, a dedicated leader in both clinical and academic ophthalmology. Dr. Ahuja has several prominent positions, or has held, including the president of the Association of Canadian University Professors of Ophthalmology, otherwise known as ACUPO, and academic chair for the Division of Ophthalmology at McMaster University. Now, as chair of the Council on Advocacy on the COS Board of Directors, she recently represented COS before the Canadian Senate Committee on Social Affairs, Science and Technology to advocate for Bill C-284, which was instrumental in establishing Canada's first national strategy for eye care. Complementing her work in advocacy, Dr. Ahuja is a pioneer in leadership development, wellness, and inclusion within the healthcare field. She is the author of the best-selling memoir, Stress in Medicine. She's a contributing writer for Psychology Today and a sought-after speaker who recently just shared the stage with Damon John from Shark Tank. Tonight, Dr. Ahuja will be talking to us about advocacy in action. Welcome, Dr. Ahuja.
Thank you very much, Dr. Dagher, for the introduction. and welcome to everyone who's attending. I'm so glad that you've taken the time to learn about ophthalmology in Canada. I have the privilege of talking to you about advocacy in action. And before I get into it, I'd like to ask you, what does advocacy mean to you? You know, the truth of the matter is that we're advocating for things all the time, and we don't really think about it. It can be as simple as, I'm hungry, I really want something to eat. You know, Mom, Dad, can I have something to eat? Our children do it, our siblings do it, our parents do it, we do it. When you're asking for something that you need and expressing something and putting a voice to something that matters to you, that's really what advocacy is about. And so today I'm going to be speaking to you on behalf of Canadian Ophthalmological Society and what we are doing to advocate for vision health on behalf of all Canadians. So in terms of disclosures, I don't have any disclosures relevant to this presentation. So when we're talking about advocacy in ophthalmology, it's defined by the actions and initiatives that we're doing to promote eye health, to promote access, to support patients' rights, to advance awareness so that we're able to address disparities and improve outcomes when it comes to vision health for all Canadians. It's extremely important because the reality is that not everyone knows what's happening in everyone's space. So for example, if I'm in vision health, I know what's happening, but as someone in the community who's living your daily life and not engaged in eye care in any way, you wouldn't necessarily know what issues are important to deal with to make sure that you're getting the optimal health that you can in terms of your vision. So that when we're looking at how we do this, there are different avenues. Education is a huge one so that people are understanding what ophthalmology is and how we fall or where we fall in the continuum of eye care. We're also trying to inform our fellow healthcare providers what we do in terms of what care we can provide and at what level we get involved when it comes to the eye care journey for a patient, and then also informing government and policymakers so that they understand, again, the differences between ophthalmology, as an example, versus optometry, where optometry is providing essential eye care services on entry, and ophthalmology, we're providing the more specialty advanced medical treatments and surgical treatments for eye care. So that informing and educating both the public as well as policymakers, fellow providers, that becomes really important to be able to ensure that everyone's aware of where we fit into the journey of care for you, for your eye health specifically. And then by engaging the community, we're able to empower you. So if you understand the differences of who provides care, if you understand the differences of the different eye conditions that can impact you in various stages of your life, it allows you to then feel like you know what you're talking about and you know what needs to be done in order to really optimize your eye health throughout the various stages of your life for yourself and for your family as well. This leads to resource mobilization as well. In order to be able to do these advocacy activities in terms of educating people and speaking on your behalf and bringing voices to these issues, it's really important for us to be able to mobilize resources, get funding, increase in-kind support so that we're able to work cohesively and with resources that allow us to really act on your behalf in a meaningful way. We have to remember that there are 8 million Canadians who are dealing with eye conditions that can lead to blindness. And so this sort of advocacy and mobilization becomes extremely important. And through that leads to different initiatives and opportunities for people to engage with resources, including the See the Possibilities website that Dr. Dagger had introduced earlier, which has a number of resources for patients and allows you to really engage with our organization in a way that you can feel informed and also have an opportunity to share your thoughts with us as well. Now, COS is involved in a number of advocacy activities. So as a poll, I'd be interested in seeing if you're aware of the advocacy activities that we're involved with, or how familiar are you with what we do? Truth be told, as you're taking a moment to fill out this poll or answer this poll, I wasn't really completely familiar with the extent of what the Canadian Ophthalmological Society does on our behalf, both in terms of our membership as well as for all Canadians. It wasn't until I came into this role that I really came to appreciate the breadth of the activity that's being done. which is kind of funny because I've been a member of the COS for about 20 years. So if we look at the results, it's reflecting that as well, that there's 17% are very familiar with the advocacy activities, but over 80% are not at all familiar or somewhat familiar. So you're in the right spot because I'm going to be sharing what we're doing with you, because there's a lot of effort that's gone on, and I'm so grateful to those people who were in these positions and in these roles before me, bringing all of this to the forefront where we need it to be, where we need the attention to be brought. So in terms of what we do at the COS, there are a number of projects that we've been working on in 2024, including position statements. So for those people who aren't familiar with what a position statement is, it's basically a very clear outline of the organization's views on a particular issue, so that it serves to provide guidance to our members, and it also serves to educate the public. We've been working on a number of different matters relating to this, including vision therapy, microcurrent technology, blepharoplasty. So we're looking at technologies, therapeutics, and actual procedures as well. And we meet on a regular basis so that the ideas and issues that are coming up in the day-to-day realm of media, or just as we know, as things are developing in the area of eye care, these issues are brought to our attention, and then we act on those on behalf of our organization, and again, those who we represent and aim to serve. It's also something that we update our members on so that everyone is in the know of what's going on. Now, we're also involved with the Canada's Drug Agency in terms of pharmaceutical products. We're also looking at workforce issues. We do know that we have an aging population with a growing demand for care, so that we're working on things to ensure that we'll be able to meet the needs. There are also non-hospital surgical centers, ergonomics, sustainability. There are a number of issues that we deal with in advocacy at the COS on your behalf. Recently, as Dr. Dagger mentioned, we were very much involved in Bill C-284, where we were able to present to the Senate, and we were instrumental in being able to have this bill passed. This is the National Eye Care Strategy, which sets the framework for enabling access to eye care for all Canadians, which is a significant mandate for COS and for the federal government as well. And so with this, which received royal assent in early November, we're able to really look at the landscape of eye care to see how we can ensure that eye care is reaching those people who are in remote areas, for example, or who are underrepresented and marginalized as well. With that, we're continuing with government conversations. Judy Schro was the MP who initially brought this forward, so we're very grateful to her for that. It was championed by Senator Ravalia as well, and of course it was approved by the House of Commons and the Senate. In all of those time periods, and now especially moving forward, we're continuing to engage with our activities with the government, building relationships, helping them understand the differences of the various partners' contributions in bringing this bill forward, and we're doing this in conjunction and in collaboration with our partners, and making sure that we really are representing ophthalmology through the development and implementation of the bill to bring that expertise to the table so that we can really help create a collaborative framework that's going to work best for Canadians from the start of the patient journey all the way through to those phases that the disease is more advanced and challenging to deal with. So we've been very, very fortunate to be able to meet with a number of MPs, as well as our colleagues and partners, to really build those relationships to work collaboratively. In addition to that, we're taking the opportunity to leverage media to increase our exposure and profile, again, to help Canadians understand what the various eye conditions are and how they can be involved with preventing the development or progression of those diseases, and how to advocate for themselves and loved ones or friends who may be impacted. And we're also looking at optometry scope expansion, which is an issue that is at the forefront one of the issues that are at the forefront in terms of being able to ensure that we're collaborating with our optometry partners and ensuring that any changes in any scope of practice are really keeping patient safety at the forefront, as we know our optometry partners want to do as well. So that we're really trying to establish those relationships and work in ways that we can really leverage and optimize the the skills, expertise, and education that we bring to the table as ophthalmology in guiding the process and working with optometry to ensure that together we're able to provide a really good spectrum of care to patients that maximizes and optimizes safety and access as well within the parameters of our expertise. So we're really excited about being involved with that and working with the Canadian Canadian Association of Optometry as well. In addition, all of these activities do help build a library of resources which are available and to the public as well as to us as members. We are also engaged with bringing resources to us to, again, work on your behalf, including our Public Awareness Fund. The Public Awareness Fund is really aimed at helping initiatives to enhance public and government understanding of ophthalmology's role in eye care and to really bring that voice to the issues, as I mentioned before, on your behalf. HEAL is another area where we're involved. Our CEO, Elizabeth Fowler, is co-chair of this organization, which is a coalition of 43 national health organizations dedicated to improving the health of Canadians. This gives us an opportunity to, again, bring eye health to the forefront, work collaboratively with our partners in healthcare beyond eye care, and to really set the stage for developing something that's comprehensive for our members, our Canadians, and our communities and all Canadians. If you're interested in advocacy, the COS does have a primer available on its website, so I certainly encourage you to look that up. How can you bring your voice to the forefront? How can you bring these issues to the forefront, whether you're a community member, whether you have a loved one who's affected by vision loss, and of course, if you're a member, this is something that is available on the members only section, but certainly there are resources that are available in the widespread literature as well that you can access if you're a member of the broader community. In terms of COS, our statement is essentially bringing it to ensuring excellence in eye care across Canada. We believe in working strategically with our partners, dedicated advocacy efforts, and our goals are really to elevate awareness, mobilize resources, prevent blindness, preserve vision, and improve overall eye health so that we're safeguarding the precious gift of sight for all Canadians. Thank you.
Thank you, Dr. Ahuja, for sharing all this with us. We'll now take a few questions. What would you say are the most pressing challenges in healthcare advocacy today?
There are a number of different challenges in healthcare advocacy, and a few of them are universal across specialties, but certainly in ophthalmology, access is a big one. We have a very large country. People live in remote areas where infrastructure isn't necessarily there, so we don't necessarily have the offices or the clinics or the surgical centers that we have in the larger cities that in Canada. So that access is really important to ensure that all Canadians are able to have their eyes examined and have disease detected early. This is where Bill C-284 really comes into play. It's actually an instrumental initiative that's really going to add to that progress, where the government's also supporting increased focus on increasing access for eye care to all Canadians. Another thing also is workforce. We do know that we have a population that's aging. We don't have the care that we're able to provide to all Canadians at this, well, actually, that's not true. We do provide care for all Canadians at this point, but we're really keeping an eye on the future workforce to ensure that we continue to maintain enough ophthalmologists to be able to provide that care. So that's another issue. And then also ensuring that all groups have access to care so we can optimize outcomes of eye conditions to our best capacity, leveraging all resources that we have.
Thank you. Another question is, how can we as members and ophthalmologists further support equity and inclusion in the medical field?
That's a great question. And I think one of the ways that I like to think about this is the patient journey, so that if we look at looking at equity and access, if you think about education, that's really key, and it doesn't have to start when someone develops an eye condition. So that if we're able to educate people even before they get the eye conditions, they can understand how do you access care and what do you need to do in order to protect your vision. And then if you develop something that needs to be seen, it comes to the providers at that point. So how can we really make sure that the providers we have represent the different communities that are out there. So we've got a lot of cultural diversity, ethnic diversity, so that if we're able to have providers that represent these different groups, that helps the patient journey as well in terms of being able to communicate with their providers in their own language, as an example. Increasing exposure to medical students and learners so that they have exposure to ophthalmology and understand that that is a very good option and a very exciting career. Having mentorship models, those are all things that can help increase equity as well. And then as you progress through the journey, making sure again that education is there in different languages, as an example. Language can be a barrier, so that if we can put materials out there that are translated in different languages, that can be very helpful as well. So there are a lot of different things that we can do from an education standpoint, and then at a policy level as well, ensuring that we have initiatives that are really being driven to support marginalized groups and to make sure that we're able to deliver care to people, basically ensuring that we can have that representation even in terms of studies and research, so that we have different socioeconomic status represented, different racial groups represented, the different cultural elements that come into play, so that we can really understand information that's coming in terms of care that's being provided and outcomes that we're getting out of those initiatives that we're driving forward.
Thank you. That's excellent. So thanks again, Dr. Ahuja. And next up will be Dr. Jabour. So we're thrilled to have Dr. Samir Jabour, who serves as the board liaison for residents and young ophthalmologists at COS. Dr. Jabour is a specialist in corneal disease, and his research is shaping the field of keratoplasty and ocular surface diseases. As the director of the Cornea Fellowship at the Centre Hospitalier de l'Université de Montréal, Dr. Jabour is invested in mentoring the next generation of ophthalmologists. He'll be presenting on barriers to corneal donation. Dr. Jabour, the floor is yours.
Thank you, Dr. Dyer, for that kind introduction. I'll just share my screen. So continuing on the theme of advocacy, I'll be talking today about addressing MSM policies, MSM standing for men who have sex with men, in Canada in terms of corneal donations. I don't have any financial disclosures that are actually relevant for this talk. So we'll be talking a bit about the importance of corneal donations in restoring sight, the current challenges in corneal donation rates, and of course, the deferral policies for MSM donors for corneas in Canada. Before we start, we're curious to actually see how familiar are you with MSM deferral periods in Canada? Are you very familiar with the topic, somewhat familiar, or you've never heard of anything related to that topic when it comes to corneal donations? So I'll give you a few seconds to answer the poll, and then we'll have a look at your answers. That's very interesting. So only 2% are very familiar with the deferral policies for MSM donors for corneal donations. 28% are somewhat familiar, and a staggering 70% is actually not familiar at all, which makes this talk more relevant for me to actually give it to you. So I'm excited to talk about this topic. So when we talk about corneal blindness, we know that corneal blindness is one of the leading causes of blindness worldwide. And the beauty of corneal blindness for most cases is it's actually reversible with a corneal graft. However, we do know that there is a big lack of corneal tissue worldwide. Actually, for every 70 patients needing a corneal transplant, there's only one that is available. Now, of course, that's a spectrum. Most countries will have a paucity of corneal grafts, but some countries actually overproduce corneal grafts. United States, Italy, Sri Lanka all have surplus of tissues, and they actually use it to export these grafts with obviously an economical benefit for them. For us in Canada, well, we're kind of reliable on our eye banks overall, but we still rely partly on the US eye banks to purchase some tissues in some circumstances at a high price of almost 6,000 Canadian dollars per graft. Hence why we should try to make it as self-reliable as possible in Canada. Now, of course, eye banks have a very rigorous screening criteria to screen for healthy cornea to be donated. Of course, we can think about infectious disease, such as HIV, AIDS, hepatitis, or other ocular conditions, such as retinoblastoma or any tumor of the eye, but also behaviors can be used as a screening tool, as you can see, to kind of eliminate donors who might be at higher risk of having these diseases, such as IV drug use or sexual behaviors. And that will be the topic for this talk. When we look back at the 1960s, you might know that there was actually an AIDS epidemic in the United States. And at that time, HIV testing were actually very unreliable. And it is true that there was this epidemic particularly touched the MSM community. Hence, at that time, there was a deferral period that was actually installed on MSM donors when it comes to organ donation, whether it's for cornea or solid organs. Now, almost 60 years later, things have changed enormously. We also know that while solid organs themselves are donated from a patient who is infected with HIV to someone who does not have HIV, have a really high risk of actually transmitting HIV, this has never been documented for corneal donation. There has actually been a few retrospective case series where, by mistake, someone has actually donated their corneas with a donor that was HIV positive, and yet the recipients have never actually gotten HIV for corneal cases, which is not the case for solid organs. And because of that, these old, archaic deferral periods, Canada still installs a 12-month deferral period for anyone who have had a sexual activity with another man for the past 12 months before the death or the donation of the cornea. Reality is actually even worse, because we do know that our eye banks are actually, most of them, certified by the American Association of Eye Banks, which actually themselves have a 5-year deferral period. So in reality, even if Health Canada installs a 12-month deferral period, the reality on the ground is that most eye banks will respect a 5 years deferral period as per installed by the United States. And you might wonder, well, is that significant? Are we actually losing a lot of corneas because of that? While we don't have granular data on this, there has been a very interesting modeling that was made by Dr. Puente from the United States, looking at both United States and Canadian eye banks. And they've calculated that almost 2% of corneal donations might be refuted based on that MSM criteria alone. So we're talking approximately about 91 corneas, which is quite significant. That's almost 90 patients that can actually be helped with a corneal graft. On top of it, it comes with a cost, an economical cost of almost $500,000 per year that is wasted on these corneal grafts. And of course, the culture and the stigmatization effect that it has on the MSM community can be very grave and very deep. Now, why is these deferral periods actually not relevant or not justifiable anymore? Well, it all comes back to our current testing for HIV. Now, when we talk about the window period, that is the time between when the initial HIV infection has occurred and when our tests are actually able to detect the HIV in that patient. And of course, the risk here is that we might have false negatives. Basically, we're missing patients who have actually had HIV, and we've donated these transplants to someone who's a recipient who is healthy. When we look at the most commonly used HIV test in Canada, this is actually the antibody test. So as the name says, you actually detect antibodies produced by the immune system against HIV. And even their window period for these tests, they're actually very available and very cheap, is between 3 to 12 weeks. So already you can see from the most commonly used test that a 12 months or even a 5-year deferral period is actually very much severe compared to what the window period of our tests have, which is 3 to 12 weeks. Even more, if you look at the newer test, which is actually the nucleic acid testing, a bit more expensive, but much more sensitive and specific at detecting HIV, the window periods drop to almost 10 to 33 days. Hence, even more of a reason why these deferral periods should be reviewed and updated. This is actually a map that I've borrowed from Dr. Puente, just to show you what has occurred in the world. Most of the world has actually have upgraded their MSM deferral policies. If you look at the green, these are actually countries who have no more MSM restrictions whatsoever. So we're talking about most of the countries that you can see. In Europe, a lot of the countries have reduced their MSM deferral to almost 3 months or even 1 month, as you can see on the map. The exception is North America. You can see, for example, that the States has the only one, and India and few Asian countries have still a 5-year deferral period. Canada has a 12 months deferral period, but again, follows American rules. And Brazil as well has a 12-month deferral period. So you can see that we're very behind compared to the world when it comes to this, to these policies. Now, Canada, interestingly enough, when it comes to corneal blood donation, they've evolved their policies, and they now use more of a behavioral-based screening method than a blanket MSM restriction. And there was actually an apology by Dr. Scheer that apologized to the LGBTQ community about the impact that this might have caused and the lack of justification for these restrictions that have been used previously on that community. Now, to move forward, well, we have to, of course, face the common fears with the public. So we need to talk about the fear of disease transmission, and we need to talk about how our eye banks are thorough enough to actually detect HIV. It's really important to address these by showing that our modern HIV testing can almost minimize the risk to near zero levels of errors, that we have very strict donor screening protocols that can be put in place to ensure that we have the utmost safety, and also discuss the fact that there has been no documented case of disease transmission via a corneal transplant when it comes to HIV. We should be installing robust testing protocols to ensure safety of donated tissue, educational campaigns that are backed by science about donation safety, testimonials from beneficiaries about the importance of a corneal graft and how this can actually affect someone's quality of life, and of course, partner with Advocacy group to promote inclusivity. Now, there's two ways to address the change of policy. We can do a simple reduction of the deferral period to 30 days. So we keep the MSM criteria as one of them. We just reduce it to 30 days. This will mirror a bit what's going on with organ donations in the United States when it comes to solid transplants. This will, as a pro, will balance the safety of donor inclusion, but will, of course, still exclude any sudden death donors where you can actually get a proper social history and sexual behavior history. On the other hand, you can actually have a behavior-based screening. And this is what for example, the CBS, the Canadian Blood Service, has done, and which could be actually another way of doing it. So instead of having MSM as a criterion to actually exclude donors, well, you can use more of a behavioral screening method, looking for high-risk activities, such as, for example, multiple sexual partners, IV drug use, or any other high-risk behaviors that can be screened in these testing. This will, of course, expand the donor pool, reduce the cost, and position Canada as a leader in this field. The disadvantage, it requires more thorough resources for implementation. All that to say, as a conclusion, that we really need some science-based policy changes when it comes to this domain for multiple reasons, whether it's for the science, for our economy, and for the stigmatization of a community. We call for support in public education initiatives and policy advocacy. I've been fortunate enough to actually be leading a group within the COS that is called Advancing Corneal Donations, where we've had an amazing group of doctors and residents and fellows that helped us to kind of set up a group of experts to kind of work and set up a memo policy that we shared with stakeholders, including Health Canada, the CSA, and to kind of work with them to be able to move things forward. It's great to hear that the FDA is actually changing and reviewing their policies, which will have a direct impact on our Canadian eye banks. We will update you with anything that comes up in this year, we hope, via our COS channels, e-blast, social media, sidelines, newsletters. So please stay up to date with this topic, because change hopefully will be coming very soon. So thank you for your attention. We'll take any questions.
Thank you, Dr. Jabbour. Let's take a few questions. There's one from the Q&A, and they're asking AIDS in the 80s, not in the 60s, not in the 80s?
It is actually the 80s. My bad. You're right.
Yeah. I think the epidemic was in the 80s, but
Right.
it's true that it had been existent in the 60s,
right. Absolutely.
70s, and it was underreported, not very well known.
Correct.
And the epidemic took place in the 80s.
Absolutely.
Yes, it
That's
is, and it's fine to say it's in the 60s. Another question we have for you is, what do you think could be done to improve public awareness about corneal donations?
So again, as I mentioned, there's different ways to actually, first of all, we should work with educational programs and campaigns to kind of educate the public about the thoroughness of our tests nowadays to screen for HIV. We can talk with people who've actually received corneal grafts and share their experience about how this might have impacted their quality of life. We're working with as working groups, for example, what we're doing with the COS, with working with different stakeholders, whether it's Health Canada or the CSA, to see how we can actually use our resources to kind of spread the word about the importance of changing these policies as well.
Thank you. And another question is, how do you see the future of corneal transplantation evolving in the next 5 to 10 years?
Oh, that's a very good question. A very broad one, I have to say, unrelated to MSN donors, but there's a lot of work being done right now, whether it's related to stem cell therapy or even keratoprosthesis. So obviously, the more we advance, the more we want to try to be less dependent on human tissue to make it more available for developing countries and even for us as developed countries. So there's a lot of exciting things in the pipeline. So we'll see what happens.
Thanks again, Dr. Jabbour. Our
Yes.
next speaker, Dr. Rishi Gupta, is a vitreoretinal specialist and associate professor at Dalhousie University. With a background in both clinical work and research, Dr. Gupta is passionate about advancing the field through education and innovation. He's also the author of Reflections of a Pupil, a must-read for those starting their journey in ophthalmology. Tonight, Dr. Gupta will discuss ergonomics and injury prevention for ophthalmologists. Welcome, Dr. Gupta.
Thank you so much for having me. I am thrilled to be speaking here on behalf of the Working Group in Ergonomics and Injury Prevention. These are my financial disclosures, none of which are relevant to tonight's talk. And I thought we'd start with a poll question. So the question is, have you experienced MSK pain that you believe is caused by work or to which work contributes?
I hurt myself today.
A little music to go along with it. So we can bring up the results of the poll. And it looks like the majority of people have experienced that kind of discomfort. So we'll start with some definitions. Ergonomics is the applied science concerned with designing and arranging things people use so that the people and things interact most efficiently and safely. And musculoskeletal disorders, of course, are painful disorders of muscles, tendons, and nerves. And why is this important for us? When we look at the literature, we see similar results to what we just saw in our informal survey question here, where the majority of ophthalmologists in different areas of the world do experience MSK symptoms. And you wonder if this might be increasing with our aging workforce, and there's no doubt that the demands for our services are not going down. Where is the pain? Well, as you can imagine, it is in the neck, the back, the shoulder, the elbow, the wrist, and the hand. And there are a number of risk factors that we need to be aware of. Repetitive movements, static loading, particularly when in non-neutral positions, insufficient recovery, forceful gripping, and sudden unstable movements. And if you think what we do day in, day out, craning at the slit lamp and contorting ourselves with the indirect ophthalmoscope, hunching over into the operating microscope and then bent over with our loops, there's no doubt that we are putting ourselves at risk. Interesting to think that different subspecialties have different risks because, of course, we do varying things. And so all those risk factors might play a different role depending on what you're doing in your week. One of the most concerning papers that we came across was in the oculoplastics literature, where ASOPers trained attendings were surveyed, and 9% in fact said they stopped operating due to pain or spinal injury. So you have this balance between wear and tear and rest and repair. And as long as these are in balance, we're probably doing okay. But when the wear and tear increases, that rest and repair goes down, that is when we are at risk of injury. And this is, of course, going to have an effect on productivity with perhaps time off of all work duties, maybe limiting our scope or our volumes. Some will retire early, as we saw in that last paper. There can be loss of income, certainly disruption to patient care, and perhaps a burden on colleagues to pick up the slack. It'll affect our mood, it'll affect our bedside manner, curtail our leisure activities, and certainly affect our general quality of life. So what's great is that a number of very prominent ophthalmologists have started to talk about their own difficulties with injury and ergonomics. So Dr. Robert Sioni says, after about 10 to 15 years, I was developing constant neck pain and upper back pain. Dr. Sunir Garg at the Wills Eye said, I started having back pain in second year residency. Elizabeth Yu, I have some underlying injuries to begin with that are just exacerbated by the strain of what we do day in and day out. Dr. Sam Maskett, I started to have significant neck-related problems, and he shared his MRI. You can see the spinal stenosis. You can see this hyperextension. You can imagine that that's sort of the position that we're at when we're at the operating microscope. Dr. Steve Safran said, I was in a lot of pain and losing feeling in my hands. It brought to attention you can't just keep hammering away at your spine because at some point it hammers back. And this is his post-surgical imaging. So we recognized that there was a problem, and this past year we formed a committee where we tried to get a good balance of height, gender, practice setting, stage of career, background, as well as east to west, and a good mix of different subspecialties. So we have comprehensive represented, cornea, glaucoma, oculoplastics, pediatrics, and retina. And so from Dalhousie, there's myself, Devin Betch, and our resident who's on the committee, Freddie Lee, Cyril Archambault from Université de Montréal, from Ottawa, Sama Sebedi, Kashif Beg, and Mike Dolan. In London, Rukeya Mather. Dr. Bellin has retired, but we wrangled him back onto the committee, which is great. So we're thankful for his guidance and leadership. He's been leading the charge for ergonomics in Canada for a long time, and we're very appreciative to have his guidance. Patrick Gouy in Calgary, and Famita Karani and Harold Jurdy at UBC. So our vision is to educate every Canadian ophthalmologist on ergonomics and injury prevention and how to mitigate risks. Our mission is to eliminate work-related injuries for Canadian ophthalmologists, and our values are those of respect, passion, teamwork, creativity, inclusion, and diversity. We have some lofty goals. Our first one was we want to really establish an annual course at the COS. We are hoping to create some high quality videos showing a colleague's story of their ergonomic journey. We'd like to create an ergonomics handbook as well as an ergonomics curriculum for residency programs. We want to send out regular pieces of information on ergonomics through sightlines and maybe some social media challenges, as well as take what's already out there and post it to the Practice Resource Center website. So very happy to say that we will be at COS 2025. Dr. Kashif Beg has been working really hard at creating our course, and so a huge thanks to him. And for the rest of the goals, we are hard at work and working on getting some funding to support all of these activities. So you will be hearing from us probably ad nauseum. So we're very, very excited about this. We've got a lot of energy on the committee, and some thank yous. I think we're very lucky in ophthalmology to have excellent leadership with Liz, Kim, Danica, and Steph. Huge thanks to them for all of the help that they've given us thus far with our work with the committee. And I'm happy to take any questions. Thank you very much.
Thank you, Dr. Gupta. There is a question. So what ergonomic adjustments would you recommend for ophthalmologists who work long hours?
Okay, so there's a lot to go through, but if I was to give one piece of advice, I always say, listen to your body, take care of your body, and move your body. So listen to your body is, when I was in fellowship, I can remember my neck is hurting as I'm doing an indirect laser, but I'm just ignoring it. I'm not listening to my body. And so much of what we do, we're just really focused on giving the patient the best outcome. And we're not thinking about our body and all the discomfort that we're putting it through. So I think we do have to listen to our body and be creative, right? So if my joints are getting irritated because I'm injecting with my right hand, and everything I'm doing with my right hand, I'm peeling packages, I'm squeezing minims, etc. Well, just think simply use a bit of the left hand for squeezing the minims and things like that. So we have to be creative and listen to our body and change things around. We have to take care of our body. So athletes don't just show up at the game. Athletes work on their endurance, on their strength, their flexibility, their mobility, their balance, their nutrition, their sleep. We have to think about these things. Life is busy, but you're only given one body. And so I think the work that we do is athletic, and I think that we have to be in shape for it. And the last thing is move your body. I actually ran into trouble with significant lower back pain, which I struggled with for several years. And one of the mistakes I was making was I thought I was doing a good job because I was sitting up straight and I was stacking my joints and I was in, what I thought was a good position. And then I actually had our injury prevention lead in our hospital come in and watch my movements, come into the clinic, come into the OR. What am I doing wrong? Help me. And he told me, well, one thing you're doing is you're just freezing. Joints like movement. And so you have to move your body. So we're very, very interested in bringing in micro breaks so that if you are an oculoplastic surgeon doing a long surgery, if you're doing a long, combined case in a retina room with a combined cataract and vitrectomy, that's, a complex diabetic case. Well, take a couple of points in that surgery just to get up, move, refocus, that kind of thing. So you want to move your body. So I will say, listen to your body, take care of your body, and move your body.
Thank you. There's a question from the audience. How successful have you or US committees been in getting instrument makers or industry to modify slit lamps and other instruments to reduce neck and back stresses?
That's a great question. And it's a very important point that industry needs to hear our voice. And that's certainly something that our committee is interested in doing, in trying to convey these points and our struggles. We don't have the largest voice as the COS, and I think partnerships are going to be helpful if we can generate some momentum with the AAO, for example, and other societies. Perhaps we may be able to accomplish some changes. But there are some companies, making small steps. So companies like UFSK have created a chair that is felt to be perhaps, helpful ergonomically, and there are other companies as well. And I have no financial interest in any of them. So I think we are starting to see small steps, but there's no doubt there's a lot of work still to be done, and we have to advocate for that.
Thank you. Thanks, Dr. Gupta.
Thank you.
Next up, we have Dr. Chryssa McAlister, the Director of Community Practice on the COS Board of Directors. Dr. McAlister is known for her work in both ophthalmology and bioethics. She is also an active educator, teaching medical students and residents in ophthalmology and bioethics at institutions like University of Toronto and McMaster University. Dr. McAlister is here tonight to discuss ethical considerations in ophthalmology. Welcome, Dr. McAlister.
Thank you, Mona. I have no relevant financial disclosures for this presentation. So our poll question is, what forms the cornerstone of the patient-physician relationship? And these virtues listed, compassion, integrity, prudence, and trust, these are all aspirational characteristics. And in virtue ethics, that's a branch of bioethics that turns to these more aspirational characteristics that help us develop good moral traits. Now, we learn the term fiduciary duty as medical students when we discuss the power imbalance in the patient-physician relationship. And the word fiduciary comes from the Latin word fidere, which means to trust. So over half of the audience did get this one correct. Although all of these virtues are very important, trust really is what we think of trustworthiness as a foundational virtue that underlies everything that we do in medicine. Now, we only have 10 minutes today, so what I'm going to do is tell you a story of a dear friend. I did tell this story at COS this year, so if you were there, this may be a repeat. But I'm hoping that this story helps to illustrate some of the virtuous characteristics that we aspire to uphold. So I first met Fred when I was 16 and studying piano performance in Halifax. Fred was in his 50s and tuned my family piano and also all of the pianos in the music department at Dalhousie University. Fred was the first blind person I met. He could hear better than sighted people. The dull sound of a footstep at the bottom of a staircase landing contrasted with the hollow step of a stair. He used echoes bouncing off buildings to navigate outside and listened for cars to know when to cross the street. He complained about how quiet some road bikes were and worried he would get hit by one if he wasn't careful. Fred had an amazing visual memory and would remember the layout of houses and buildings where he tuned, giving the illusion of seeing the objects he could smoothly avoid. Sometimes, he admitted, they changed the layout without telling him, and he ran into things. Fred was born sighted. At age 8, he found an abandoned empty barrel with a group of friends and lit a match to look inside, not knowing it was used for gasoline. It exploded in his face. He spent the next few months in hospital in New Brunswick with bilateral corneal scarring. His school principal told his father that Fred would no longer be able to attend a traditional school and advised he be sent to the School for the Blind in Halifax. At that time, cornea transplants were not available in the Maritimes. Before meeting Fred, I hadn't spent any time considering what it meant to have vision or what it meant to lose it. As ophthalmologists, we know that vision for us and our patients is often the most prized sense. Placing our patients in a particularly vulnerable position when faced with vision loss, and us in a position of power, where we have the ability to restore vision and prevent blindness. Which makes even more concerning the discussions with young ophthalmologists I have had multiple times over the course of the last 2 years about a move from a patient-oriented model of care towards a business model in ophthalmology, where the virtuous characteristics that define the way we practice are being overlooked to enhance profitability. And as we see these profit-driven practices expand, I am particularly worried about role modeling and the importance we know mentorship plays in cultivating virtues. As physicians practicing in Canada, we are expected to uphold the CMA Code of Ethics. Founded on values and principles, the code recognizes that our practices are a process of active inquiry, reflection, and decision-making concerning what a physician's actions should be. And the virtues described, though not exhaustive, are the characteristics that we aspire to uphold. Compassion is the first virtue listed in our Code of Ethics. And I would argue that from compassion flow many of our other virtues: honesty, humility, integrity, and prudence. Compassion encompasses so much of what it means to provide care. Compassion. A compassionate physician recognizes suffering and vulnerability, seeks to understand the unique circumstances of each patient and to alleviate the patient's suffering, and accompanies the suffering and vulnerable patient. Now, Fred's story is a tragic one, a senseless accident that resulted in permanent blindness. But it is also a love story, because at the School for the Blind, he met the love of his life and future wife, Gloria. Gloria was also born sighted, but developed an aggressive form of juvenile glaucoma and had one eye enucleated as a child and her second eye enucleated as a young mother with 2 small children. Gloria lived a happy and fulfilling life with Fred despite having no vision. She stayed at home and cared for their two-sighted children, and Fred worked tuning and repairing pianos to support the family. Fred and Gloria would walk around the neighborhood together in the evenings. By the time I was in medical school, Fred had had 12 cornea transplants, all of which worked initially, but eventually failed. And his most recent one was slowly rejecting, making it harder for him to work and function independently. The difference between some vision and no vision is a big difference, he said. Losing his remaining vision not only risked Fred's independence, but also Gloria's, who relied on Fred for many tasks. At that point, I was a fourth-year medical student, and Fred was distressed he could no longer see well enough to do their evening walks. Integrity. A physician who acts with integrity demonstrates consistency in their intentions and actions, and acts in a truthful manner in accordance with professional expectations, even in the face of adversity. A few months later, I went on a student elective in Boston with cornea specialist Dr. Klaus Dolman, a legend in ophthalmology, and I told him about Fred. He said that the Boston K-Pro, an artificial cornea transplant he had developed, would be just the thing, and one of his star fellows, Dr. Mona Dager, our COS president, was soon going to be starting this procedure in Montreal. In 2008, I was a PGY2 at the University of Toronto, and Fred traveled to Montreal to see Dr. Dager. She booked him into her clinic on her first day back from maternity leave and planned to do keratoprosthesis surgery once they had a donor cornea from Nova Scotia. Prudence. A prudent physician uses clinical and moral reasoning and judgment, considers all relevant knowledge and circumstances, and makes decisions carefully, in good conscience, and with due regard for principles of exemplary care. Later that year, I visited Fred and Gloria at their home in Halifax. Fred was struggling with his vision and looking forward to the surgery. Gloria, on the other hand, was more worried about risks of an innovative procedure. What if he loses the vision he has, she said. After multiple surgeries, Fred had already lost the vision of his other eye. Thinking back, I am struck by Fred's vulnerability and desperation, his need to do something both for himself and for Gloria. When our patients are faced with vision loss, they really depend on us to guide them through the decision-making process. And this is true also for more curable diseases like cataracts. Even when they are faced with optional non-insured services, they really trust us and expect us to advise them of what has true value for them. Titled The Doctor, this painting by Sir Luke Fields is often used to demonstrate the importance of trust in the patient-physician relationship. Although titled The Doctor, Sir Luke Fields places the child, the patient, at the center of his painting, with an imbalanced highlight on the physician over the parents. But imagine for a moment the parents' perspective, the deep despair they would feel in their helplessness and need to rely on the doctor in whose hands they have placed their dying child. And the next time a patient says, "I trust you," as we find they often do, think of this painting and the burden of privilege and responsibility that your patient is trying to communicate to you in this declaration of trust. Later that year, Fred underwent a keratoprosthesis surgery using the Boston K-Pro with Dr. Dager, restoring his vision to the best it had been since he was a child. He could see 20/25 uncorrected. Fred described to me what it was like to see so clearly. "It is almost disorienting," he said. He could read addresses on envelopes, see planes flying in the sky, read license plate numbers from a distance. He wouldn't let Gloria do anything in the house. "It is so easy to cut vegetables as a sighted person," he said, "or pour a cup of tea. Gloria was always burning the tip of her fingers as she felt for the water approaching the brim of her cup. I just wanted to do everything for her," he said. Fred's story conveys the incredible power we have as ophthalmologists to restore vision. It is why we have all pursued careers in ophthalmology, and we are thanked daily by our patients for their good outcomes. But Fred and Gloria's story also emphasized the importance of virtues in medicine. As a compassionate physician, to recognize suffering and vulnerability, to understand unique circumstances and to alleviate suffering. I wanted so much to help Fred get the care he needed. I knew his story, and this motivated me. But like Fred, all of our patients have stories. And if we cultivate compassion for our patients, we will naturally do what is best for them, no matter the care model in which we work. Humility. A humble physician acknowledges and is cautious not to overstep the limits of their knowledge and skills or the limits of medicine, seeks advice and support from colleagues in challenging circumstances, and recognizes the patient's knowledge of their own circumstances. Fred enjoyed 2 years of normal vision, but then in 2011, I was a PGY4, he developed acute glaucoma. His tube shunt became blocked by vitreous. He required surgery that developed in hypotony, that resulted in hypotony maculopathy. And after a complicated course, Fred was left with low vision. In our code of ethics, compassion is also described as accompanying the suffering and vulnerable patient. When our patients face the limits of medicine and need to adjust to vision loss like Fred, or complete blindness like Gloria, we need to accompany them, to support them, to recognize both their suffering and their strengths, and to reflect on our own discomfort at not being able to cure eye disease, and our ignorance of what it truly means to be a person living with vision loss. Gloria, a strong woman, wife, mother, and homemaker, is someone to be admired and not pitied. I think often of Fred and Gloria, their resilience and life successes despite their visual disability, their happiness together. Their story inspires me as an ophthalmologist to uphold and cultivate the virtues that affirm our commitment to our specialty and to our patients. And I think of how ophthalmologists were responsible for helping them to maintain a simple goal, to be able to walk around the block together, arm in arm, in the evening. Thank you.
Thank you, Dr. McAlister. It was very moving when I heard it the first time at the COS Annual Meeting. It's still very humbling to hear it now. Thank you so much for this wonderful presentation. We won't take long. Just one question, if you don't mind. How can we at COS encourage our membership, both trainees and those in practice, to reflect more on the virtuous characteristics of a physician?
I mean, I think the best way would be if we make it a priority at meetings and in education for trainees. If we show that a discussion of this nature is valued more, which I think we could do, it would be a more impactful way for trainees to, I think, develop a more robust understanding of the challenges we face and some solutions that they could address.
Thank you. Our final speaker tonight is Dr. Adam Muzychuk, Chair of the Annual Meeting Planning Committee. Dr. Muzychuk is a cataract, refractive surgeon, and anterior segment surgeon with fellowship training in cornea and external disease. He is known for his work in ophthalmology education and clinical trials, particularly in presbyopia-correcting lenses. As chair of the Annual Meeting Planning Committee, he is instrumental in planning our upcoming events. Tonight, Dr. Muzychuk will provide us with an exciting preview of COS 2025 and also the new AI stream. Take it away, Dr. Muzychuk.
Thank you, Mona. And I really wish I had gone first. Thank you to all the panelists for the amazing discussions. Here are my conflicts of interest. None of these are relevant to tonight's talk. The Canadian Ophthalmological Society is dedicated to advancing eye care through innovation, education, and advocacy. Our annual meeting serves as a key platform for sharing knowledge, connecting with peers, and discussing the latest advancements in our field. Before we get into this year's highlights, it's important to acknowledge the history of our annual meeting. The meeting's been a cornerstone of our society for 87 years, aimed at fostering education and collaboration amongst ophthalmologists. The meeting was launched in 1937, and it's evolved from its early focus on clinical topics to encompass emerging technologies and interdisciplinary discussions. Attendance has grown dramatically from 300 at the original meetings to our current projections of over 1,500 attendees. Past topics have included advancements in surgical techniques and treatment protocols, illustrating our commitment to staying relevant. As we move forward, we continue to engage with our members to ensure the program continues to meet their needs and expectations. Let's look at some key statistics regarding the upcoming meeting. As I mentioned, we anticipate 1,500 or more attendees, reflecting the growing interest in our meeting and program. Our program will feature 60 sessions or more, 18 world-renowned keynote speakers, and over 300 invited speakers. Feedback from past attendees has shown an average rating of excellent, highlighting our commitment to quality. We also offer numerous networking opportunities to facilitate connections amongst professionals attending. So here's a polling question, and this looks a lot like an OCAP question. We're coming up on that time. The 2025 COS Annual Meeting offers opportunities to earn the following maintenance of certification credits. So the COS Annual Meeting, I guess we'll wait for a second to get those polling results. Perfect. So yes, the COS Annual Meeting is an accredited group learning activity with the Maintenance of Certification program at the Royal College. We offer section 1, 2, and 3 credits. So who are we? The Annual Meeting Planning Committee is a group of dedicated volunteer surgeons who work tirelessly together throughout the year to deliver this exceptionally high-quality scientific meeting. We work alongside the entire COS team. As you can see, all ophthalmological subspecialties are represented. And how do we do it? Session chairs of subspecialty groups develop learning objectives based on the needs assessments that are distributed annually. Session chairs select keynote speakers and faculty and help them develop presentations that are balanced and evidence-based. Planning for the annual meeting begins largely 1 year in advance. However, some of the building blocks for future meetings are actually planned up to 4 years in advance. Creative development begins in the early summer to align for release of the sponsor prospectus and early e-blasts. The call for abstracts goes out in early September. The review process takes place in the fall, and the final abstracts are used to plan subspecialty sessions starting in January. Every year we host around 20 keynote speakers who are leaders in the field and internationally renowned. They give multiple talks during our marquee current concept sessions and throughout subspecialty sessions. This year, as mentioned, we're excited to introduce a new topic stream, AI and virtual reality. This session will be led by COS member Farah Santaki. These cutting-edge technologies are vital to enhance our clinical practices and improve patient outcomes, and this will allow attendees to explore innovative developments in AI within our field. Traditionally, the meeting's been organized by subspecialty, focusing on clinical care, but this session will highlight early-stage developments in AI and VR, fostering collaboration across subspecialties. Feedback from this innovative new symposium will help us shape planning for its ongoing involvement in the future. Here's a list of some of the many speakers we will have the opportunity to learn from in June. There will be 7 skills transfer course wet labs, including these 4 new courses. STCs are very popular and often hit capacity early, and advanced registration is required, as well as for the self-assessment programs, the Symposium for Young Ophthalmologists and Residents, and our Medical Student Symposium. Now, let me share with you why you should attend this year's meeting. This is your opportunity to engage with leading experts and innovators in our field. It's also an opportunity to revisit some of the basics of clinical practice, to keep our day-to-day skills sharp, and to gain skills at sessions and skills transfer courses that are outside our typical practice patterns. The annual meeting is an opportunity to network with peers, global leaders, and our partners in industry. And aside from the scientific meeting, this is our annual opportunity to see your former co-residents, trainees, fellows, supervisors, staff, and toric course roommates. So for this reason, for me, wherever the meeting's held, it always feels like coming home. So in conclusion, this year's meeting represents a pivotal opportunity for growth and learning in the field. I'm also excited to say we're going to have a speaker from the American Academy of Ophthalmology join us to discuss their experiences in advocacy on issues we're similarly facing, and they can answer your burning questions at current concepts. I encourage everyone to register early for early bird rates and to participate actively in this year's meeting. Looking forward to 2026 in Montreal, we're working on exciting new additions we'll hope to announce soon with the Annual Meeting Planning Committee. And I can say that the dedicated staff at COS are hard at work at securing an amazing venue for 2029. It's my privilege to serve as the chair of the Annual Meeting Planning Committee. And on behalf of the committee, I'd like to say that we're looking forward to welcoming you all to Vancouver in June.
Thank you so much, Adam. And we're really all looking forward to attending COS 2025. I have one final question. I'm mindful of time. What are some sessions that young ophthalmologists can look forward to at the annual meeting?
They have there's the Young Ophthalmologist Symposium is always a very involved session. They have world-renowned speakers that come in, and it's always the meeting that I wish that I could attend as an attendee. I know that we have wet labs that are planned, as well as a young ophthalmologist facing symposium where they're going to be sharing ideas, exchanging different. There's going to be a program on transition to practice, among other ones. So we also, I believe, have a young ophthalmologist facing wet lab. So that should be great.
Amazing. Thank you so much, Dr. Muzychuk. So what a fantastic series of presentations. We've heard so much about the exciting developments happening in our field. I don't see any more new Q&As in the tab, so I'd like to thank you all for joining us tonight. I'd like to thank the speakers and the whole COS staff for the preparation for this forum. It's been wonderful to hear from our speakers about the work they're doing to shape the future of ophthalmology. If you have any further questions or would like to get more information, please feel free to email us. We're always ready to respond. I wish you all a great evening and thank you very much for attending.